10,000 individuals. So that's the official definition. And there are more than 6,000 rare diseases in human beings. And in fact, 1 person in every 17 has a rare disease. Around 3 million people in England. And everything in media is either size of a football pitch or size of Wales. Do you know what's the population of Wales, Martin?
3.5 million.
3.0164 from Wikipedia from 2011. So I think this could have made a much more splash in the media that included that one line, that equivalent to size of Wales, but obviously they didn't do that and it's not hot in the press. So what I'm trying to say is rare is common, it's size of Wales, really, just in the UK. And there are many people with rare diseases who do not have access to specialist services, causing delay in diagnosis, slow treatment, and isolation for affected individuals and their families. Sound familiar, I guess? So, coming to the sciencey bit now, before talking about an update for these things, I think it's important to just show you what we already know about this pathway. So, I think it's been alluded to a few times in previous 2 talks as well, but essentially, vitamin B12 is bound to food. Pepsin and acid take the B12, they separate it from food. Intrinsic factors secreted from stomach, and it binds to B12 in the first part of the small intestine. And if you don't have the gene that codes for intrinsic factor in your body due to a genetic change, then you have congenital intrinsic factor deficiency. So these children present with signs of B12 deficiency, and they have low B12 levels right from the start, so just a few months of life. And this complex of intrinsic factor B12, that is taken up in the small intestine, the last part of it. And again, there are a couple of receptors for that. And if you have changes in either of these 2 genes, you develop a condition called Imerslund-Grasbach syndrome. And again, that children will present with B12 deficiency very early on in life. Once it's in the intestine, it has to go into blood, and again it needs a carrier protein for that, which is called transcobalamin. And again, if you have mutations in the gene that codes for transcobalamin, you have transcobalamin deficiency, in which your B12 levels might be normal in blood, but you have all the signs of B12 deficiency, because you're not able to put this B12 into your cells. And there is a special transcobalamin receptor in the cells, which identifies this complex and brings it in the cell. And this receptor was only identified 3 or 4 years ago. And then from there, it goes into an organelle of cells called lysosome, from where it has to be transported out. And then these are all blue bits, are all different enzymes which are important in different cellular processes. So Professor Smith was talking about homocysteine. So that's why homocysteine is raised, because you need B12 for this reaction, in which homocysteine is converted to another amino acid called methionine. So if B12 is not there, this reaction cannot happen, and homocysteine accumulates and it rises in the body. And the other thing that we talk about is methylmalonic acid. So that's because of another part of this reaction. And again, similarly, if this reaction doesn't take place, then methylmalonic acid levels can rise in the body. So that's probably, yes.
But what I understand is that you can have a good B12 level in your blood, but then it doesn't mean that you have a good cell level of B12. Is that correct?
Yeah, so all these red CBL, A, B, C, D, E, F, etc., these are all inborn errors of metabolism of vitamin B12. So children with these, with mutations in genes that code for these enzymes, they have normal levels of B12, but they cannot metabolize it within their cells, and still they can develop all the different problems, much more severe actually than pernicious anemia. So the importance of a rare, coming back to that, we've learned all this about vitamin B12 through patients, individuals who have problems in different parts of this very complex pathway. So if we didn't have those patients, we would have still been at a very primitive stage of understanding vitamin B12 absorption and metabolism. So it's really, really crucial, I think. So what's been new in the last couple of years in this field? So we thought we knew all this, that was clarified, but there was a paper in Nature Genetics a couple of years ago, which shows that mutations in a gene called ABCD4, very nicely named, easy to remember for me, it causes a new inborn error of vitamin B12 metabolism. And what they showed was this particular molecule is needed for B12 to be released from the lysosomes within the cells. So if you don't have this particular molecule, your B12 gets trapped inside the cell and it cannot undergo the metabolic pathway that it should. And it creates a number of different problems in those children. So that was quite interesting and novel. We thought we knew about how B12, what it does in the cells, but actually it's completely different. There was another paper which showed that mutations in this particular gene called HCFC1 can also cause inborn error of vitamin B12 metabolism. And that's very interesting because previously all these disorders were thought to be related to particular enzymes. So all these blue oval things are enzymes, whereas this HCFC1 is not a vitamin B12 enzyme at all, but still it causes vitamin B12 kind of inborn error of metabolism. And what it is, so I'll just have to probably go a step back. So we've got 20,000 genes in every cell of the body, and they're not working all the time. So cells, the genes that are important in skin are different from genes that are important in blood, from heart, etc. So it's only a few subset of genes that are active. And there are certain genes which tell the cells which genes should be active. So HCFC1 is a gene which tells the cell that we need to increase the level of these enzymes in the cells for B12 metabolism. So it's actually a completely new type of B12 metabolic disorders. And it's also worth mentioning that it has a different inheritance pattern altogether. So all the other disorders that I talked about, they are where parents are carriers and they then have a child who's affected with the disorder, a bit like cystic fibrosis. Whereas this particular disorder is X-linked, which means that women are not affected, but boys can be affected with this particular disease. And women can have the genetic change, they can function completely normally, but if they have a boy, there's a 50% chance of them passing this gene mutation, and they can have very severe problems. So it's a new inheritance pattern and a new molecular mechanism of an inborn error of B12 metabolism. So I think it was really, really interesting. I've put the table here, but I won't go on about that. So those were the rare disorders which are essentially related to B12 absorption and pathway. But there are some other rare disorders as well, where pernicious anemia can be a feature, although they're not directly related to vitamin B12. So this paper appeared in New England Journal a couple of years ago, where it's basically an immunodeficiency. So it causes patients who have mutations for this gene, they can develop fungal infections, quite severe fungal infections. But interestingly, in the family that's been described, one of the individuals also had pernicious anemia, and there were other individuals with different autoimmune conditions. So again, this is something to think about, that if someone has candidiasis and pernicious anemia, one must think about that, could this be genetic? But it's not entirely surprising, because so we compiled for a review article a list of disorders in which pernicious anemia has been described. And many of these disorders are immune deficiency disorders. So it's not surprising that there's another new immune deficiency disorder in which pernicious anemia is a feature. And we all know that pernicious anemia is an autoimmune condition, so that's an antibody towards these cells that produce intrinsic factor in the stomach. So actually immune deficiency can also result in autoimmunity and dysregulation of immunity. So the next bit which I'm going to concentrate on, and hopefully it won't take too long, tell me if it's all too much, then I'll just stop here. Okay. So the next bit I'll talk about is the genetic factors which are common but have low effect. So we were talking about rare disorders previously, but we're sort of changing track now. So, well, pernicious anemia is not a common disease, but B12 deficiency probably is relatively common. And we know that complex or common diseases are multifactorial. So that essentially means that there are genetic factors and there are environmental factors which act together to result in a particular disease or disorder. And if you understand what are those genetic factors and environmental factors, you can understand the disease better. So one thing that scientists like to do is to lump and split. So I'll explain what I mean by that. So we knew that there's this B12 deficiency, but now we can divide them into different groups. We know about congenital disorders of B12 absorption. We talked about congenital disorders of B12 metabolism. And we also know that there is dietary B12 deficiency. We know that there's food cobalamin malabsorption. We know that there's pernicious anemia. So we've split these disorders, and that's really important because treatment for each of these groups of conditions is completely different. Similarly, I think what is emerging now from the stories that you're all telling is actually pernicious anemia. We probably need to split it a bit further. People who have more hematological problems against people who have more neurological problems, people who have more psychiatric problems. So there is further splitting that is possible. But you can also lump things together. So pernicious anemia, and I think Dr. Chandy is going to talk about this, we often see that there is an association of Addison's disease, diabetes, vitiligo, thyroid disease occurring in the same person together. And this comes under the umbrella of autoimmune syndromes. And the advantage of lumping things together is that things that you learn from one disorder, which is related to another, you can apply that knowledge to pernicious anemia as well. And a lot of this lumping and splitting is underpinned by genetics. So actually understanding the genetics of common complex disorders is also very useful. And the government has been very active in this field recently because now we've got the technology and the tools to be able to do that. So I don't know how many of you were aware about this, but about 6 months ago or so, David Cameron announced this big push towards doing 100,000 genomes from the UK. So there would be 100,000 individuals whose whole genome would be sequenced, and they've set up a company to do that. So there's actually a big push from the government to understand the genetic basis of common disorders as well. And there is evidence of genetic susceptibility to B12 deficiency. So we know about familial clustering, we know about the relationship with other autoimmune conditions, and we know that genetic factors have been identified in those other autoimmune conditions. So that tells us that there must be similar genetic factors important for the common form of pernicious anemia as well. And there have been studies in the last 2 or 3 years where it has been shown that B12 levels in general population are known to be affected by genetic variations. But what has not been done up till now is it's not been shown that if genetic variations are important in B12 deficiency in cases of pernicious anemia. So those are slightly different things. So in general population, genetic variations affect B12 levels, but whether those are important in patients who have B12 deficiency or not, that's not been studied up till now. So that's a snapshot from a paper from 2.5 years ago, where they studied B6, B12, and folate concentrations with homocysteine levels, and they found 3 genes to be important to determine B12 levels in these normal, unaffected patients, unaffected subjects. This is another paper from China, so this is just about Chinese men, and again they found 5 more genes that were associated with B12 levels. And there's been another paper just this year in which they've identified a few more genes. So actually within the last 2 or 3 years, we now know that there are at least around between 10 to 20 genes that are associated, changes in which are associated with B12 levels in the general population. And interestingly, most of these genes are around the B12 absorption and metabolism pathway. So there's a lot to learn, and it's not just humans. There is data about other species as well. So the milk B12 levels that you get depend on the genetic status of the cow from which the milk is coming. So it is quite interesting. So conclusions. Genetic variants play an important role in rare and common forms of B12 deficiency. Our knowledge about this is progressed quite substantially in the last few years, but there's still much more research that is needed to identify genetic factors that influence common causes of B12 deficiency, such as pernicious anemia and food cobalamin malabsorption. And these factors may actually determine your susceptibility, presentation, severity, your response to treatment, and complications of the disease. And again, another way to sell these to funding bodies is, if you learn these, you can actually translate these findings into other common disorders, so thyroid problems, diabetes, etc., which are very common. You can actually learn about them as well. So thank you very much for your attention, and apologies if I've not included your paper, but there was limited time.
We have just time for just one question. We've got some coming in online as well.
Are these slides going to be made available to us?
As long as the speakers give us permission, yes, they will. They'll be available on the website, yes. Dan, there's a question coming from the internet?
Yeah. Hold on a second. Right. Tired asks, my hemocytosine is still high despite 3 monthly injections. What can I do to correct it?
So again, I talked about genetics, so it's probably slightly different. So one would say that maybe having more frequent injections and getting to an expert who might be able to investigate it a bit more in detail, because B12 deficiency is not the only cause of low homocysteine. So see someone a metabolic doctor who knows about this area.
There's the TMG, trimethylglycine, which is a nutritional supplement that they can take, which will lower.
There's also another thing called betaine. So
that's the same.
Is it the same? So.
We can't take any more. We're running a little late already. I know that a lot of you have come here especially to see our next guest. He is here, he is in the building, and it's Dr. Joe Chandy.
everywhere. See if that correlates with that. And like when you're sitting around the sun, you actually think, how long do you think?
I'm not sure it's working up. You're going to have to use the clicker. Use the mouse.
When was this? Like years ago. Was the one in 50 a day?
Hello, everybody.
Hello.
Thank you, Martin, for inviting me. I think this is the 4th time I've been here.
Could you speak into the mic, please?
Right. All the previous times I have spoken about B12. And now you may notice I am deviating a little bit from that, but very well connected to this problem. Before I go into it, both Dr. Smith and Dr. Banka mentioned about we must think about other conditions as well, not just B12, in order to achieve maximum reversal of signs and symptoms. Even if you get frequent injections every day, still there may be signs and symptoms which need to be dealt with. Dr. Siddharth mentioned about APS, Autoimmune Polyendocrine Syndrome. So what are those endocrine glands? If you underactive thyroid or overactive thyroid, pancreas causes type 1, type 2, and also the parathyroid, hyper or hypo, ovary, polycystic ovarian disease, adrenal, hypoadrenalism or Addison's disease, pituitary gland can be affected, even the thalamus and suprathalamus can be affected by this autoimmune process. Then you may notice I am mentioning about ME, MS, chronic fatigue syndrome, fibromyalgia, and previous speakers mentioned about depression, psychosis. So for a moment, you are all expert patients, and of course clinicians here as well. Can you think for yourself, what is the cause of those conditions? Both speakers mentioned, if we know the cause, then we can treat. If you do not know the cause, you cannot treat. So for a moment, please think, what causes those? Now, as I mentioned, I've been working on B12 and treating patients for the last 32 years, since 1981. And then, why am I now going on to something else? So I never thought about that until last Friday. Just a week ago, a very important medical colleague rang at the last minute while I was in the surgery and said, I want to come and see you. I thought, what next? So I said, I finished the last patient at 12, so you may come then and I will see you. He apparently came early, and the staff told me he was looking at all the photographs, all the presentations, and articles that came in newspapers for the last hour, half an hour. So at 12, I came out of my clinic and went into the boardroom, and we both sat down. And he was, of course, very straight. He asked me straight away, when did you come to UK? I said, 1967. How old are you? So I said, I will be 73 in January 16th next year. Gave him the answer. Then he asked me, I notice you have worked in Southend-on-Sea Teaching Hospital, Liverpool Children's Hospital, Brighton Royal Alexandra Hospital, all teaching hospitals, and you were going to become a pediatrician. Why have you become a GP? I kept quiet. Why did you come to Horden, of all places, which was now and before the most deprived district in the country? He again paused and waiting for an answer. So I told him, it is destiny that I came here. So he again paused and he was looking for an explanation. So I told him, I got married in 1969 after 2 years of coming here, brought a young wife who had never been out of her village, and she became pregnant, and I was studying for MRCP in pediatrics. Then I get a phone call from a friend of mine, will you come and do a GP locum for 2 weeks? Because his lady partner is admitted to hospital with a heart attack. Just 2 weeks. I said, I got a young wife here and I'm busy. No, please come and work for us. After 2 weeks, he find out that doctor, lady doctor, Chesney was the name, she passed away. So he asked me to stay because he found me hardworking and dedicated. Though I didn't have any general practice experience, I soon learned. He begged and asked me to stay. So I said, okay, I will stay for a while. And then after 6 months, he gave me a partnership agreement because he wanted to keep me. He will give a partnership in 11 years' time. I'm an independent sort of person, so I realized if I stay here, I cannot progress. So I started to apply, and the first job interview was for this job in Horden, next to Peterlee, County Durham. And Joseph was just 5 weeks old. So I got a day off, got into my old car, and drove up. All the way, halfway, the silencer broke down. So if I stop, I will be late for the interview. Still I came 5 minutes late, and baby screaming because he was hungry, and this car making such a noise. Everybody who is waiting for the interview is looking, who the hell is coming? And one of the managers saw the baby crying, young wife in sari, so they got a convenient seat and agreed to make the milk for the baby. And all the doctors, there were about 10 doctors who were experienced and senior to me. And when the result came, I was given the job. I thought, my goodness, I haven't even seen the surgery. I had to say yes or no. So I said, okay, yes. And then they said, this is the way to the surgery. I've never been in that place. So somehow we found the surgery and came to the surgery, which is an old building, which had been a practice building, as well as the next door was the mortuary in those days. When people die, the body is brought next to it, next to our house. Doctor lives there. There was no heating. I didn't know how to light the coal fire. I said, no, is that what I said? Yes. Now I can't go back on my word. So I stepped into the surgery waiting room and everyone was smoking. All in wellies and this and that. Then where is the secretary? Oh, she's in that room, a poky little room, and she was smoking. Then I had a chance to see the doctor. 6 foot, I think 6'6", giant of a man. Patients thought I'm the doctor's son. They're waiting for the doctor to come. When I saw the doctor, he was also smoking. I told my wife, I don't know what mistake I have done, brought you into this place. Anyway, as you can see, I stayed. And On the second day, I was asked to be on call, not only for my practice, single-handed practice of 3,500 patients, also another practice of 20,000 patients. Didn't know the way, nothing, but somehow I scrambled into the car and went to this visit. And the second day I left the car at the front door because I didn't want to put the car in the garage, because if I may have to go out. Tucked into the bed at about 1 o'clock in the morning, I had a big bang. When I looked through, there was a coal wagon, completely destroyed my car. Went out and I said, come in. And I took the telephone to ring the police. He said, oh, don't ring. I am your patient. Please don't ring. So that is how I started in Horden. And I'm still there. It was very tough. I had to light the coal fire, make sure my wife and baby was okay. But 2 years later, on a cold morning, Joseph's sister, baby's sister, was found dead. I've been a pediatrician. Of course, it was cot death or sudden infant syndrome. All my friends who came for the funeral said, Joe, don't stay here. It is not a good sign. You have to go away. But of course, I believed in destiny, and I was going to move. So this gentleman was listening to all this, and then he said, how did you come across B12? And then I showed him how I came across this, the mother and child. I delivered this baby, and then the mother started to come with recurrent anemia and all the neuropsychiatric symptoms. I then knew about Brahmin women I used to treat. And that led me to ask for B12 level. And the hematologist wasn't prepared to do the B12 because there was no macrocytosis. Then and even now, many believe unless there is macrocytosis, there is no B12 deficiency. So that was the first case, and then you may notice we have left a booklet, hundreds of cases affecting every system in the body. Then he said, we notice that you are ordering many cortisol levels. You are an outlier. What's the explanation for that? Then I said, in fact, I have prepared a presentation for the Pernicious Anaemia Society, and I'm going to speak about it. So he said, let me have a look at it. Hugo, can you show me which one?
Should be this one.
Right. You know who it is? And he suffered from 3 conditions. One was B12 deficiency. It was known, he said, if it wasn't for the B12, I wouldn't have been able to make the decision for the Cuban blockade. That is what Kennedy said. Then what else he suffered from? Addison's disease or hypoadrenalism. He had a 3rd condition. He broke his back in the U-boat accident in the World War. And you can see he was admitted to our hospital, St. Thomas, I think, and he was given the last rites. That serious was, of course,